And I think we can start. So it's a great pleasure to have the next webinar of the Peripheral Nerve Surgery Group of the ENS. It's been quite some time, so I hope everybody of you in the audience is, ready to jump back into nerves. We prepared case-based and rapid-fire webinars. So Karl Fugelholm from Denmark and Willem Pondak from the Netherlands and myself, we will present highly individual solutions for patients with peripheral nerve problems, and what to do and what to consider and what to think through and the strategies why we address a certain problem in what way. And then it's time for discussion. After each case, we will have nice opportunities to discuss. And I would like to ask the audience to use the questions and answer button to send the questions so we can read them out and go through them. So please feel free to put your questions in that. And we are looking forward to having you with us for the next, let's say, 1.5 hours. So this is more or less the time that we aimed at. And the first speaker, I think we will just start over. The first speaker will be Kare, and he will address a problem that is not very far away from the central nervous system. So, Kare, please.
Thank you. I'll just share my screen. Okay, so I hope you can all see my screen. I would like to thank Christian for leading this webinar and for inviting me to talk about this. I'm a skull base and a peripheral nerve surgeon, so this will be in the borderlands between skull base surgery and peripheral nerve surgery. I'm going to talk about masseter to facial nerve transfer, and this is going to be, as Christian said, case-based. I'll just see if I can move. Yes, so the history of the patient is a 45-year-old lady, and she was referred to the Trigeminal Neuralgia Center in May 2015, and that was about 3 months after she presented with right-sided shooting pains in the jaw when touching the teeth in the right side of the mouth. So this was fairly typical of trigeminal neuralgia, and she also started then medical therapy, but she had severe side effects, and some of the drugs did not work very long, and she ended up having side effects that were not acceptable to her. And therefore, she was, in October 2016, referred to neurosurgery to the trigeminal neuralgia team with an MRI that showed vascular contact on both sides. At this stage, the patient had been an inpatient for 4 weeks, and she was wheelchair-bound due to side effects from the medication. So she was not happy with the situation, and we can look at her coronal MRI, the Fiesta 3D, where we can see that on both sides that we have vascular contacts. So she was offered to have a microvascular decompression on the right side, and that was performed 4 days later because she was in a very bad state. So we did it subacutely, or actually the MVD team did it subacutely, and placed some Teflon between the superior cerebellar artery and the fifth nerve routinely, as you know, nothing happened during surgery that could be blamed for her post-operative facial paralysis and hearing loss on the right side. Her trigeminal pain disappeared completely, and she was happy. Despite the facial palsy, the hearing improved over days. And she decided that, her facial pain was so bad that she was ready to accept the facial paralysis. 3 months post-op, there was an MRI again with the Fiesta 3D showing the internal auditory canal here on the right side and on the left side, and there's some blurring here. And as well, if you look below here on an axial scan where we see the trigeminal nerve, there's also some blurring around, and it was suspected that there might be some inflammation, but it may also just be the Teflon. So there was no real explanation for her deficits, but of course we all know that if you do MVDs, you sometimes will have cranial nerve problems. So 11 months after the MVD, there was no improvement. You can see her picture here. You can see the right-sided facial palsy, which is quite bad. Was a paralysis actually, and she was referred to the peripheral nerve team. At that time, she had a light trigeminal neuralgia. That means that some of the pain had come back. She had sensory loss in the face and the tongue. She had a complete hearing loss on the right side, and she had facial paralysis on the right side. So we are now 11 months after an injury to the facial nerve, and we have facial paralysis, and we have to consider what to do. She also had dizziness and balance problems. But at this stage, we will consider facial reanimation because there's little hope that she will recover spontaneously. We have left a long time for that, actually maybe a little longer than we should. We normally wait for about 9 months if it is after an acoustic neuroma, or if we know the time of the lesion. But now we're already 11 months. So facial reanimation is something, as I said, to do with timing. We have a time window, and for patients of this age, the time window is roughly a year. You should always do it, even if it's 13 or 14 months. You should still do it because it can still be okay. But if we talk about dynamic facial reanimation, this is the time window. Because we can always do static procedures. If we're looking at dynamic procedures, there are some different choices. You could go in and replace the segments in the cistern with a sural nerve graft. That would be major surgery, and it would also take a long time for the nerve to regenerate. So we would not consider that. The accessory to 7 has been done before. It's not something that we do. We prefer to do 12 to 7 or 5 to 7 nerve transfers or cross-facial if it's a young patient. If it's an older patient, the Labé myoplasty of the temporal muscle can be done. And then, of course, there's a lot of static procedures that can be done in combination with this. So we have to choose, and there are some special issues here that we need to address. Sorry. So we can do a 5-7 or a 12-7, and we are 11 months out. And we also have a fifth nerve problem, which is a problem that has to do with the trigeminal neuralgia, and there's also some sensory loss now. Therefore, if we are going to do to use the fifth nerve, we need to know that the masseter nerve has a normal function. Now, to consider doing facial nerve procedures, you need to know the facial nerve anatomy in detail, both extracranial and intracranial anatomy. And to do that, you can go to this virtual 3D extra and intracranial facial nerve anatomy that is part of the 3D Atlas of Neurological Surgery. You can scan this code, and you will come directly to this atlas. And later on, you can go and look at the anatomy if you feel that you need that. Looking at the 12-7, that means the hypoglossal to facial nerve transfer. This can be done in the way, and this is the way that we do it, that was described by May in 1991. You can see the white line here is the outline of the mastoid process, and here it is of the jaw, of the mandible, and the stylomastoid foramen will be around here. The nerve has been disconnected at the stylomastoid foramen, and a sural nerve graft has been placed between the facial nerve and the hypoglossal nerve below the ansa cervicalis. And this is end to side so that we keep the function of the tongue. And this is what we used to do mostly 10 years ago. The problem with this is that it'll take quite a long time to regenerate. And being out at 11 months, we would rather use the fifth nerve if it works. And the 5 to 7 nerve transfer that was described by Spira in 1978 is something that is very close. You can see the facial nerve and the masseter nerve. Is quite obvious that something can be done with these nerves. Of course, they lie in different anatomy here, and we will have a look at that. But before we consider this further, we need to know whether the masseter nerve is normal. So we did an EMG of the masseter nerve that was normal. And also, we have not seen any contraction in the face at this stage. But we still did a facial EMG to see if there was a lot of reinnervation going on. There wasn't. There was a little bit, but there was still no visible contraction, and we felt that we had to do something further to help the patient. So therefore, now 12 months after the MVD, after all these preparations, we were ready to do the 5-7. So that we decided to do due to the time window, and the 5-7 is a direct nerve transfer, and it has a very quick regeneration with function returning after 3 to 4 months.
Okay, Danilo, kom maar, ja, dat is de.
So if we look at the face here, we can see the parotid gland, and the facial nerve, as you know, lies in the parotid gland, and we also have the parotid duct, the duct of Steno, and we don't want to damage this, and therefore we go into the masseter muscle 3 centimeters in front of the tragus and 1 centimeter below the zygomatic arch. And you find the masseter nerve between the second and the third layer of the masseter muscle. So you have to come in quite deep into the muscle to find the nerve, and it's nice to have a stimulator with you to identify when you get closer to the nerve. It takes about 15-20 minutes to find it, but it's quite easy. And if you look at the nerve, you have to take it quite proximal. It can be tempting to do more distal cut, but the more distal you go, the more axons you lose, and you actually need about 1,000 axons to give a good donor. So therefore, you should not be tempted to go more distal to get more length on your masseter nerve. In fact, it's better to get more length of your facial nerve. You can here see the patient where I have outlined the different branches of the facial nerve as I believe they might be. You can see the temporal branch, the zygomatic branches, the buccal branch, and there will also be cervical branch here to the platysma. You don't need to keep that. Can sometimes be a problem to turn the facial nerve back on itself to the masseter nerve if you want to keep all the branches. That also goes for the for the frontotemporal branch here. So you're mainly focused on reinnervating the zygomatic and buccal branches. There's a lot of variation in this anatomy, and there's no predominant variation that you can rely on. So you have to find the nerve out here somewhere and trace it back one branch backwards and see how the anatomy turns out to be in this particular patient. And here you can see the skin dissection done here in the smash plane. It's a facelift incision that you use. You could see the incision planned here. This is a typical facelift type incision, and you can therefore also do a facelift for the patient, which in many patients is a good idea because they have quite a lax cheek. And so after the skin dissection, you start to look for the branches at the edge of the parotid gland. You find the branch here, and then you follow it backwards through the parotid gland, and you simply have to divide the parotid gland, and we haven't had problems with that. So you divide the parotid gland along the nerve all the way back, and then you find the other ramifications and you dissect along those, and finally to the stylomastoid foramen where you cut the nerve, and you have to take the posterior auricular nerve and the nerve to the digastric muscle in order to turn this back on itself and take this and bring it over here somewhere. So you can see here, this is a zygomatic branch being dissected, and this is deep into the masseter muscle where you find the masseter nerve, and you can see it gives off branches like we saw before, and we can cut the distal part of it, and we can use both of these branches, one for the zygomatic branches and one for the buccal branch. So this is what has been done here, zygomatic to the main branch of the nerve and the buccal to the minor branch of the nerve. And then it's simply just to close and do your facelift on the way out. This also requires that you have the company of a plastic surgeon, and so I do this together with the plastic surgeon who provides service for the facial paralysis for all patients in Denmark. And it's very giving to work with another specialty like that. So this is a lady afterwards at rest, or this was before. This is at rest, and this is when she clenches her teeth. So you can see that there is a nasolabial fold here, and that the symmetry is pretty much okay when she's trying to smile with closed mouth. So we consider this a House-Bragman 3. It's a reasonable result, and this is what you can expect with a nerve transfer for the facial nerve, also with a 12-7. But now there were new problems because after this she had return of the trigeminal neuralgia, meaning that she had severe shooting pains when she was clenching her teeth, and this was what she was doing to use the nerve transfer. So that was a big problem, and we decided then to re-explore with microvascular decompression. We found new vascular contact, and we solved it with some fluffy Teflon. 7 and 8 we found with normal structure, which also supports maybe the notion that it might have been either stretch of the nerves or inflammation due maybe to the Teflon, we don't know. She had some effect of this new procedure, but she still has need for low dose oxcarbamazepine and lamotrigine, and she is able to use her face again by clenching teeth. And I called her last week to get permission to use her case today and talk to her, and she was happy with the situation. She has little pain in her face, and she could move the face, but of course it was far from a normal situation, and this is what you sometimes have to tell the patients before all this that there has to be a realistic expectation of how this can end. So I think we should have some questions and comments maybe. But before that, I just want to remind everybody that we have the first ever chronic subdural hematoma meeting ever, in Copenhagen in May, and you're all welcome to come. It's a scientific symposium, and you can find details looking it up on the internet. Just write chronic subdural hematoma symposium, you will get there. So let's go back to the question and comments to this case. Maybe my co-panelists wants to make some remarks first. I don't know.
Well, first of all, thank you very much, Kari, for this excellent case. And I see Lucas made it, so welcome, Lucas. Well, there are no questions so far from the participants. So, Willem, please go ahead.
Yeah, thank you, Kara. It's a very interesting case, and it's difficult because you have a number of cranial nerves that are damaged. So the first question is, what do you think about the timing of the referral? Were you happy with that, or were you? Because I think the referral at 11 months is relatively late. Would you have wanted to see these patients more early?
Yeah, I think this was a case of complications in a patient, but it was also a case of hopefulness with a surgeon. I mean, that when you make a complication like this with a procedure like this, where you expect to have little complications, then of course you're very hopeful that things will will solve themselves more or less. So I guess this was the reason that my colleague came to me quite late and asked me, if I thought anything could be done about this. I didn't know about the patient until 11 months, and I think it was left a little long. As I said, we would normally start to do something at 9 months, and then we would have a good time to do the transfer before a year. Because normally when you plan something where you have two specialties, you will normally have, something like a month to make the investigations you need and to book the case in a normal flow in the department. So no, I was not happy with the late referral, but this is, I'm sure you all have the same, that patients are referred late. So because there's very little knowledge about this time window.
So there are two comments from the question and answer. One is thanks to the patient for permittance of her presentation. I think we all completely agree with that because, well, the face is something very delicate. And as Kara already pointed out, and I think this is one question that is discussed all the times when do facial reconstruction, is about the emotional reinnervation or the let's say that the restoring of emotional mimical function. So this would lead us to using either the contralateral facial nerve or to do as you proposed, or at least thought through, to have an autologous reconstruction of the damaged ipsilateral nerve. Could you comment? What do you think? Was it the late referral to have you the masseter being used?
You can actually have social function in both with the 12/7 and with the 5/7. There has been functional MRI studies very nicely showing the cortical representation and the overlap between the 5th and the 7th, and the 12th and the 7th, both of these have overlaps cortical. So in younger patients, you will tell these patients to smile every time they say hello to people. So every time they give the hand to somebody, they have to smile by clenching the teeth. Every time somebody tells a joke, they have to clench their teeth to smile. And then eventually, if it is young patients, they will smile without clenching the teeth. And we have several patients where this has been the case, but it doesn't happen with patients that are older than 50. So if it's young patients, they will have social function even without a cross-facial. There is an addition to the 5-7 that has been introduced in that there's a sural nerve graft taken from the opposite side of the face, from a small branch of the facial nerve on the opposite side, and that will ignite the function on the side of the transfer. And do not ask me how this works, because I find it difficult to believe how this can work. But there has been good results with this, and I think it's also something that should be considered, especially if it's not a young patient.
Okay, I think this is a very important message, something that the audience needs to know, that you have an excellent setup of an interdisciplinary work. So these patients are not just, let's say, just operated on, but you have the setting for them to assess them interdisciplinary as you have the situation in Leiden. There are more questions. One is because I think what you addressed with the recurrent trigeminal neuralgia after the transfer. There's one question from Iqbal Karal. Radiofrequency rhizotomy is good in this case, or you wouldn't use it for the recurrent one?
This is something I don't know so much about, because I'm not doing the microvascular decompression, also not doing we use the balloon compression technique mostly, and then glycerol. We don't use radiofrequency. But you could argue that you could also use the gamma knife. All these treatments, I guess, is something that you can, if you cannot control the pain, as in this situation, actually it can be done now with medication. If you cannot control the pain with medication, obviously I think that is something that could be considered, because you're not going to compress. If you're going to compress the motor component, of course, that's going to be a problem. But I'm not really sure how you would do that without actually. I think the balloon compression would be preferred in this situation, because it is not irreversible. So I think that might be an idea to do balloon compression in this case.
Just one question, just out of interest. Do you think the recurrency of the neuralgia has anything to do with the transfer, or is it just, coincidence? Hell, I know, but just
it had already returned. The pain disappeared completely after the first procedure, even though there was immediate cranial nerve deficits. So the recurrence was already there at the time where we decided to do the 5-7, and this is why we did the masseter EMG, to make sure that that part of the nerve was not damaged. So I'm not really sure.
Okay, there are more questions from the participants. One is from Wieneke van Vollenhoven. Would have been a combined 12-7 plus 5-7 an option in this case?
No, it would be difficult to use the facial nerve. You would have to split the facial nerve for the two donors, and I'm not really sure how, because you would have to move the tongue to use 12, and you have to clench the teeth. You have to really be sure that tongue is not caught between the teeth when you're moving and clenching teeth at the same time. I have never heard about this, but I guess, I mean, you always have to think horizontal when you have these problems. You should not exclude anything from the beginning. You should think horizontal before you think vertical. So you should not be locked in any, routine that you have. You should consider every possibility. So I like the idea. I just, hadn't thought about it.
Well, I completely agree. To exclude an option is always the worst option because, as you stated in the presentation, there are, well, a lot of ways to approach this problem. It can be static, it can be dynamic. You can use muscle transfers and local muscle transfers, free muscle transfers. So I guess if you if you ask 10 or 100 specialists doing this, everybody will come up with a different solution depending on the background, of course. So I think the most important thing is, as you just said, to be aware of all these options and to raise realistic expectations in the patient.
Yes, one last thing. As was said by Hugo Fisch to Michael Gleason in Switzerland in 1984, I think, when Michael Gleason was he was a registrar with Hugo Fisch, and Hugo Fisch said to him, "It is one moment of your time, or it is a lifetime of agony for the patient." And what he was talking about was using time to save the facial nerve or to repair the facial nerve. So take your patients by the hand. If they have this horrible complication, you have to take them by the hand and make sure that they get through this in the best possible condition. And you have to involve everyone that needs to be involved and not, hide yourself or the patient in this situation. And I think that was the last I would say with this.
Well, this is cool. There's one more question from Maisie Matthew. Thank you for the remarkable presentation. Do you advise tackling bilateral conflicts at the same sitting or one after the other in your experience? So did you ever encounter bilateral facial nerve palsies?
Yes. We had a case of a 12, 13-year-old girl that had a pilocytic astrocytoma removed from the floor of the fourth ventricle and had bilateral facial paralysis because both the colliculi were damaged and also had bilateral abducens palsies because of the abducens nuclei were involved. And so she came out like Mona Lisa. She had no movement in the face at all. And there was no chance of any regeneration because at the colliculus it is oligodendrocytes making the myelin, so there's no regeneration possible there. So we did in this case an early bilateral 5 to 7, and that started to work quite quickly on both sides. And she has a nice smile today with the mouth closed. And the other thing was that she did not have the concomitant problems that many of the facial palsy patients have because she still had the intermedius nerve. So she had still the tears, she had the saliva, she had the glands in the nose, and the function of the stapedius muscle and so on and so forth. So there was still a lot of function there, and it was only the motor function that she lost, and we restored that. So she has a normal life today. So yes, it is possible to do it on both sides, but this is a very rare situation I have only seen once.
Okay. There's one more question from Christian Scheibe. What do you think about the direct 7 to 12 end-to-side anastomosis with mobilization of the facial nerve from the petrous bone without interposition? So basically what
Yes.
Mariano Sokolowski, for example, proposes.
Yes. So you have for this to drill the mastoid to follow the nerve up to the to where it comes close to the middle ear, and drill it out of the fallopian canal, and by that you can gain another 12 millimeters, and you can turn it back from there, and from the stylomastoid foramen you get another maybe 12 millimeters, and in many cases you can actually turn it back on itself and get down to below the ansa cervicalis and do an end to side direct graft there. That is definitely possible. I have not done it because I had good results with the swirl nerve graft, but obviously we all know that a graft is worse than no graft. So I guess there is a point there. But since we have discovered how fast the patients recover with the 5-7, we have actually not done any 12-7 since, because it's a very fast and reliable way to renovate the face. The only problem is that you get less tone in the face to start with. So you have to do a lot of exercises with the face to have the same tone in the face as you will have with a 12-7. So it's the only place where a 12-7 is better. It provides a better resting tone in the face.
Mm.
With good exercise, you can actually get that resting tone also with a 5-7. Just have to tell the patients.
William, do you have, or Lucas, do you have experience with the drilling out the petrous part of the facial nerve and do the direct coarctation? I don't have, so I use the 5-7 as well.
Yeah, we used to do this quite a lot, and I think that Martijn Malissi was one of the co-authors of a paper on it. And it's just like Kara said, that you have a nice resting tone. But nowadays, because of the shorter renovation distance, we often choose also the 5-7 transfer.
So there are no more questions from the participants. Any comments left? So, Kara, thank you very much for this very nice case to open up this webinar. And I will kindly ask Willem to take over and talk about femoral to obturator nerve. Willem.
Okay, thank you. I hope that you're seeing my screen now. So I will discuss.
Perfectly.
Okay, good. I will discuss one case for the individual solution in peripheral nerve surgery, and I chose to present to you a femoral to obturator nerve transfer. So I have no disclosures on this presentation. It concerns a 16-year-old female, and she had a history of hip dysplasia, and she was treated in April a few years ago, and they performed a Gans osteotomy. So this means that a part of the pelvis is rotated outwards to get a better congruence in the hip joint. And 6 weeks after surgery, during her training, she noticed that she had a diminished strength in the upper leg, and she described it as an outward swinging of her leg. And this particularly bothered her after longer walks, but also when she was standing for a longer period of time. And of course, as a Dutch girl, she noticed this while cycling, that her leg couldn't be positioned properly on the pedal. And she also, in her youth, she did some horse riding, which was not possible anymore after the surgery. So 6 months post-operatively, she had a persistent paralysis of the adductor muscles. We did an EMG of the adductor magnus muscle. We found fibrillation, positive waves, and there was no pattern in the adductor magnus muscle. So we concluded there was a lesion of the obturator nerve, without any clinical or EMG signs of re-innervation. So we contacted the performing orthopedic surgeon, and he explained that during the surgery, a Homan retractor is positioned subperiostally in the obturator foramen, and we thought that this was the moment that the obturator nerve was damaged. So this is the postoperative X-ray of organs osteotomy, and you see that it is a relatively large surgery, and so this is probably where the obturator nerve got damaged. So if you have an obturator nerve lesion in the pelvis or at the exit of the pelvis, you have a number of options which we considered. So first of all was, of course, a primary nerve reconstruction, but we were quite hesitant to explore the obturator nerve proximately, because it was probably the proximal stump was to be found inside the pelvis and in a scarred environment. There are no vital options for secondary surgery, for muscle transfers, or so this means that we ended up looking for options for a nerve transfer. So in those days, it's just been published, the obturated femoral nerve transfer. So this was in 2010. And here you see that both branches of the obturator nerve are cut distally and swung towards the femoral nerve. And we found 1 year later, there was a case report of a femoral branch to obturator nerve transfer for thigh adduction. So this caught our attention, and of course that we read this paper. And this patient, she had a oncological surgery in the pelvis, and she also reported this outward swinging of the leg and tripping because of the loss of obturator nerve function. So this was the illustration from that paper. And you saw that one of the branches of the femoral nerve was coaptated to the distal obturator nerve. So we decided this would be the way forward for our patient. And what we did an identification of the obturator nerve during surgery. We found no reaction upon electrical stimulation of the adductor muscles. We chose to target the anterior branch of the obturator nerve. So we divided it as proximal as we could. And then we dissected 2 branches of the femoral nerve. And so these branches were chosen quite randomly to fit the size of the obturator nerve, and also to spread the deficit in the quadriceps muscle. And these branches were tunneled underneath the saphenous vein. So here you see the patient, so it concerned her right leg. So we did an incision in the skin crease. We identified the obturator nerve here, and we identified the femoral nerve right there. Here you see the branches that we selected. We cut them distally, tunneled them under the vein, and then swung them medially into the direction of the obturator nerve. And we did a direct coaptation with 3 10-0 sutures, which was enhanced by fibrin glue. So here you see the image through the microscope. So you see it's rotated a little bit. So this is the femoral nerve. These are the 2 branches that are tunneled, and this is the distal obturator nerve. So here you see that we direct the 2 branches toward the anterior branch of the obturator nerve. You see here the 10-0 stitches. You see that we have a nice size match of the anterior branch, and we put some tissue glue, fibrin glue, to secure the coaptation. So after 4 months, we saw some tension in the adductor magnus muscle, and 8 months after the surgery, she reported that there was a clinical improvement. She had less outward swinging of her leg. on clinical examination. She had a strong adduction of her leg. Her physiotherapist measured this as 20 kilograms of force, and we only saw modest atrophy of the quadriceps muscle. There was no functional deficit, luckily, and she also could squat and stand up again with a strong quadriceps muscle. So I think this is a quite short and straightforward illustration of a nerve transfer, and I think that in these cases, be creative with your nerve transfers. Nowadays, lots of nerve transfers have been described, so if you look for them, then you probably find a nerve transfer that can suit your patient well. Thank you very much.
Thank you, William. Excellent. And you are showing perfectly, as you just said, the individual solutions and whatever is in, at our disposal to use it. There's a question from an anonymous participant. In my country, there's a huge number of explosive injuries, but due to lack of resources, we cannot operate those kinds of microscopic operations. Could you please suggest any educational or collaborative opportunities that individuals can benefit from so we can gain this kind of experience? I think, well, we have our foreign minister here, Lucas. Lucas, can you hear us? So I think this is something that we completely agree, everybody, on that. Of course, anybody who wants to learn these techniques, because this is not magic, this is something that you can learn with good anatomical knowledge and microsurgical techniques. This is something that you literally can do anywhere on this world with, let's say, not equipment as you use for, I know, navigated cranial whatever surgery, but this can be done with very, very basic stuff. So I think all of us would be very happy and very open to have people here to learn these techniques. Lucas, do you want to comment on this? There was a question of how it's possible to learn these techniques from our group.
Well, you can answer, I think, better than me, because you know this actual situation, of course, like we are. But generally speaking, I told you I am in outpatient clinic, and I have some now small gap, so I'm following, but I'm not able to follow completely the presentation. As far as I saw, Core and William gave a nice, excellent presentation. But to answer the question, I think it's necessary to the person who would like to learn this should, let's say, take some time for learning that, and starting from the theoretical and cadaver anatomical lab, not cadaver, anatomical dissection, and then the cadaver lab following some mentorship of some experienced surgeon, and then to come to the clinical fellowship. This, let's say, a steep learning curve, but generally speaking, can be learned without any problem.
Definitely.
If I understood good, yeah.
So
yeah, this is my opinion. If I understood the question correctly, yeah.
Yes, definitely. I think feel free to send any one of us an email so we can organize. So please feel free to contact us. Kari, please.
I think for that question is, you have to know the principles. You cannot, as has been said already, you cannot know every single nerve transfer before you do it. And all of us have done things for the first time, because if we didn't do it, nobody would do it. So I think it's reasonable, even in this time and this learning atmosphere that we have, that we create a toolbox for ourselves, so that we know how to do things, and we can make custom solutions like Willem just showed, that you make the solution that you think will help the patient, because if you don't do it, nobody will do it. And the other thing is, you can come to courses. There are courses in Germany. There's a course in Copenhagen. It's not running this year, it's running next year. We will soon update the 3D atlas of neurological surgery with virtually any nerve transfer that you can think of. We have a whole week in April where we will do 3D imaging of all the nerve transfers, and so you can at least see how they look in 3D on that resource, which is free. So you can go there for free. You can come to Copenhagen. It's not quite free, but in 2025, come to Copenhagen and have fun with us, learning how to do a lot of different nerve stuff. So there's lots of opportunities. I think you should select your fellowships with accuracy. So you can go to Christian or Willem, or you can go to London. You should not go to Copenhagen, because you need to go a place where there's a huge caseload, so that if you're there for a month, you need to be presented with a huge caseload, and we don't have that in Copenhagen. But you can come to the course in Copenhagen, and I will always be willing to answer any mails I get, of course.
We have some a nice caseload for let's say 8 to 10 surgeries for a week, from which are 3 to 4 nerve transfers. And then if you want to come, you can come. I mean, the person who would like to come can come. But what I want to say is that Kåre, you mentioned this 3D nerve transfers presentations that you have. This can be also very interesting in terms of presenting in some of the webinars in a forthcoming period for this.
Yes, I think what's going to happen is that we are going to create a study room in the metaverse, where you can go with your virtual reality goggles, and you can walk around with your friends there, and you can turn around all the specimens. You can even walk into the specimens and walk on the brachial plexus if you want. This is the future, and this whole movement is led by Thomas Biriev from Bulgaria. And he's very keen to do all this, and we are going to present some of it in when we get to Sofia later this year. But we already have this museum where we can walk in with VR goggles, and it's a great experience. And you can even take 3D reconstructions of your own patients, and you can then align them with the anatomical dissections there, and you can prepare for surgery and so on. So there's a lot coming in that area where we can actually train without being in the lab, but just being at home with our VR goggles. I don't know whether it's just smart or whether it's useful. We will have to let time show, but at least we're working on it.
Perfect. So there are more questions from thank you very much.
Yeah,
So,
I think I want to add one thing. I think that a lot of transfers have been described in literature, and you can find if they were successful or not. And I think one of the key things is to check if you have a good donor to acceptor axon ratio. I think this is important, but this will be found out also during when you found out that you have a good size match of your acceptor and your donor nerve. That this will guarantee you that you will have sufficient axons to reinnervate the muscles. So the second thing I wanted to share with you is that I had the opportunity to be with Cesco Soldado lately, and he told me that he is frequently on missions to different countries. And there's one thing about the seal that you should know, that even if you let it thaw and you don't refreeze it, so if you have leftovers from tissue, you can use it. He claims you can use it for months if it's thawed. You maybe have to wait a little bit longer before it hardens, but it's still very usable. And I saw it with my own eyes that some tissue that was a leftover from months ago would still work for a nerve grafting or a nerve transfer.
This is very important. As you said, there have a lot of nerve transfers being published. Something that people tend to forget, that nerve transfers means you take out a nerve, a fascicle from a working nerve, and put it into something not working. So there's always a donor side deficit. So this is something that you need to keep in mind. And of course, these the results are of a lot of, not of all, but a lot of nerve transfers work perfectly. But you always need to, as Willem pointed out, to be aware of what you're doing. So there are more questions for Willem. One is, have you published the case?
No, we have not. I think it's very difficult nowadays to publish case reports.
Yeah.
And as this nerve transfer was already published earlier, we decided not to publish it.
Okay. Then the next is, which branches of the femoral nerve did you use? Did you address?
So we chose to use branches which we thought were expandable. So this means that we looked for branches, for instance, for the vastus medialis. If I don't remember precisely if there were 2 or 3 branches, but we took only one. So we did not completely denervate one of the quadriceps muscles, but we took a branch from, I think, vastus medialis and a branch from rectus femoris, which also was innervated double. So we did not completely denervate any of the big parts of the quadriceps muscle to spread the deficit.
Yeah. Excellent. There's one more question going back to Kare. I think we can quickly answer that. Is what would you do if you transected the facial nerve during VS removal, vestibular schwannoma removal, transplant right there in the cerebellopontine angle? Or you would wait and or maybe in the same session, do a nerve transfer or something else?
Yes. I would say that if you are able to operate on a vestibular schwannoma, you should also be able to do a direct repair, as you can sometimes do if the facial nerve has had a elongated route around the tumor. You can sometimes do an end-to-end, but mostly you have to take a swirl nerve graft, and the right place, as Willem said, you have to match the size of the nerves, and where you're going to take the swirl nerve is not on the leg, but on the side of the foot, and where it has already divided. So you take one of these divisions of the swirl nerve, and that has a perfect size to do a graft. You don't have to stitch the graft in. You can secure it with spunkoston and fibrin glue. This you have to do in the same surgery. And I think you should just, train to do that, or, get somebody in that can do it if you can't do it, because that is by far the best option. If you know the facial nerve is gone, you have to do something in the same surgery. There's many good reasons why you should do that. But of course, if you have never done it before, there may also be many good reasons not to do it.
Thank you. So there's one more question for the contact email. So we have an email of our section. It's pns@eans.org. pns@eans.org. So if you send a mail there for any question related to our group and our work, feel very free and you're very welcome. Plus, we have an ongoing session of business meetings online, which are completely open to everybody who's interested in the PNS field. So please contact Anna Recht from ENS, and she will have you in. So everybody who's interested in peripheral nerves is mostly welcome to join our group. So any more comments on Willem or by Willem?
No, I have no more comments. Thanks.
Okay. So we move on, and now we do the exact opposite of what Willem just proposed. I will try to share my screen, because what we did was to use the obturator nerve for to use the obturator nerve for the femoral nerve. So the story of the patient is he had a very severe motorcycle accident with a disruption of the left lumbosacral plexus, and he had left. The only thing that was left was some hip flexion, distal muscles completely gone, knee extension completely gone. The problem is that he also had a brachial plexus lesion on the left side. He had massive neuropathic pain, and this is something that influenced a lot on our strategy how to move forward, was that he had a lot of concomitant lesions with a lot of and severe infections after multiple abdominal surgeries. So we talked to the patient and asked him what are his priorities, because he had the left arm gone, the left leg gone, and the right arm had an impairment of radial nerve and ulnar nerve that are recovering, fortunately, but he's very handicapped with all this. And he clearly said, well, my first priority is that I want to walk, be able to walk, and I want to be able to walk independently. The second was that he wanted a pain reduction and some arm function. So what we suggested to him was, since the gait was his main issue, and he had the problem that whenever he stood up on his two legs, the left leg wouldn't hold him and he would fall. So because the knee was not stable. So we thought that in his situation, to somehow get function back to the femoral nerve, especially for the pure extensors, so to speak, would be the first priority. This leads us into thinking about the anatomy. So this is the lumbosacral plexus, which underlies a lot of variants, as we already heard and saw in William's beautiful talk. So what we need to consider is that the ipsilateral side, so the left side in his case, is completely gone. So we cannot use the obturator, we cannot use anything deriving from the sciatic nerve. We have nothing that we could use from the femoral nerve, because the L2 part, that is for the iliopsoas, of course, we need to preserve. So the second thing is that due to his all his abdominal issues and all the surgeries that he had there, I was very reluctant to go into the abdomen and do a retroperitoneal reconstruction of the lumbosacral plexus, because I thought that the risk of damaging and having a severe rebleeding was too high. Even I discussed this with our abdominal surgeon, and he's very experienced and he's courageous, but he said this will not end up well, because the colleagues that were treating his patients before were happy that they could close finally could close the abdominal wound without any infection. So what we came up with, that we needed to do an extra abdominal or inguinal grafting, and that we don't want to damage the only leg that is working, his right leg, in a significant way. So what to do? The most dispensable nerve, maybe even if Willem just told you a different story, but this is not a Dutch girl, so you need to keep this in mind. This is a German young man. What we thought is to use the gracilis branches of the obturator nerve and to do a grafting, because this will never work end to end, as you have seen before in the ipsilateral side, but that we need to use a grafting to get from the healthy obturator side to the affected femoral nerve side, and to use these branches exclusively for the rectus femoris muscle and the vastus intermedius muscle. So the pure extenders are not the adductors or abductors of the quadriceps muscle. So what we wanted to have him back was knee extension enough to have a stable standing, and hopefully in the future to be able to walk. This leads us to what also was addressed already, to the topographic anatomy of the femoral nerve. So where do we find what? So this is medial, this is lateral. So this is basically a left femoral nerve. And you see in this beautiful paper, you see the intraneural topography of the fascicles. So you see that what we wanted to have is vastus intermedius and rectus femoris that were more on the medial and lateral side of the femoral nerves. So this is our target. This is the exposure of the healthy side. You see the gracilis muscle, you see the retractor, and once you gently pull it back, you will find the obturator branches to the gracilis muscle. And in his case, which was something very good for him, in the end he had three branches that supplied the gracilis muscle. So taking two would not completely denervate the gracilis muscle. This is important because we want to have this muscle for future reconstructions even of the brachial plexus as a free muscle transfer. So we left one to still supply the muscle and took two for the grafting of the contralateral side. So this is what you see here, is that we put the loop and the retractor is coming from the other side. So from the effect side, we pull this loop through from the right side to the left side. And at this loop, later on, I will suture the grafts to have them pull through the cutaneous tunnel to not need to open up everything. So now, from the healthy right side, we move to the affected left side and have this is the femoral artery, and soon we will see the femoral nerve. And here you can already see the two grafts. So this was one sural nerve from the right side, and it was brought already from to connect the both sides. So they're in place. And now we dissect out the femoral nerve, and you see it's well, it was still some scarring there. You will see in the next slides too. And this is already the coaptation. And you can see that we try to remove the scarring as much as possible, but still there is some. So I was happy, but not too happy with this. But the fascicles that popped out after cutting back the femoral nerve, well, didn't look too bad. So this is the coaptation on the affected side. Now we move again to the healthy side, and you see the grafts. And next thing is to have the coaptation with the obturator nerve. And this was done in, I think it was 2.5 hours of surgeries. And 7 months post-op, the patient came to our outpatient. and this is his function. So at first I thought it's a trick.
Versuchen Sie es mal gestreckt zu halten, so ein bisschen.
So I asked him to keep the knee extended.
Nochmal machen.
And you see that he needs to move his right thigh to activate the knee extension. So this is 7 month post-op. It's he cannot walk with it yet. He has he can stand on the leg for very short time, but whenever he bends the knee, the leg will not hold him yet. It's too weak yet. So he was rescheduled to come to outpatient in 3 months. So that's the case. Thank you very much.
Very interesting, Christian.
So, well, we felt that this was the only opportunity to have him some function back. The problem, of course, is his pelvic muscles and the gluteal muscles, because the sciatic nerve is completely gone. So he will need some orthesis or something to have a stable pelvis. But I hope that after 7 months with the length of grafts of 12 centimeters each, he's a fast recoverer, definitely. And I hope that he will proceed in this way to have a stable, well, somehow a stability to be able to stand on his own feet without help, and to, you know, to be able to move in his maybe home to without help or devices. Let's see. Please, Willem.
Yes, so I think this is a very, very interesting and creative solution for this patient. The one thing that I would be very interested in, how he would be, if he would be able to rewire cortically his walking. I can imagine that he could stand, because then in both your legs you sort of less do the same movement and you activate the same muscles. But if you are walking, then you have to relax one leg and put strength in your other leg. So I would be very interested in if he will be able to learn this to control this movement.
Well, this is a very, very important point. This was my main worry, to have him, as you just said, to have these issues of rewiring, because he needs to learn to, well, relax and and activate at the same time. So, well, I hope, and he's in an excellent program, because in Germany we have a system that is, if you have anything work related, you get into another system. And this system is very well equipped with money and a lot of therapists and everything, so he gets the best physiotherapy possible. And they are using biofeedback systems to let him learn how to activate and deactivate at the same time, to relearn. And he's super motivated. And the good thing is he didn't have a brain injury. He didn't have a traumatic brain injury. So his brain is not harmed. So I'm well, right now I'm just hoping that he will do it. And of course he will not run a marathon with this, but to have him some daily life function back, I think that would be excellent if we can manage this.
I think that it's very good that you have this team of physiotherapy and biofeedback training. And I think this is something that we should put into practice more than we do now as nerve surgeons. And I think that there are a few papers out by Dominic Powers Group from the UK, who have a very specific rehabilitation program, for instance, after common nerve transfers, like a triceps to axillary nerve transfer, like strengthening your triceps while the axons are still growing. And I think that this is something that we have to put into practice more and more to get these patients an individual-based training based on the surgical solutions that we chose for their nerve transfer.
How is this in your, I mean, in your institution, you have this fantastic organization with this interdisciplinary team, and you're very closely working with your physiotherapists.
Yeah,
So-
but we have not because often these these patients go home to their physiotherapist close by. So we are working now on a program to educate this physiotherapist. Now we do it often on an individual basis and write a letter and explaining them what to train and what to expect. But I think we have to connect more to the physiotherapist and the rehab specialist to learn them what we do and to learn them how they can make a function out of the nerve action and the muscle actions that we can reproduce.
I completely agree. So what I tell the patients, or I give them the number to call me. I want to talk to the physiotherapist because a lot of patients can tell them what there is, what has been done. But I had some examples that the physiotherapist called me and told me, "Did you really do this, or is the patient crazy?" Because he told me he needs to whatever flex the wrist to have elbow flexion or extend the arm, as you just said, for the deltoid, and they wouldn't believe. So they thought the patient was crazy and Googled something that is not true. So I think
sometimes the patient comes to the outpatient clinic and says, "Well, I can do nothing," and then you say, "Flex your wrist," and then to his
Boom,
amazement, then there are some biceps.
yeah,
So this is something we really have to organize better than we do now.
definitely. There's a question, and this is very interesting too. Can transcranial magnet stimulation play a role in predicting corticalization after nerve transfers? Do you have any experience with this?
No, we don't have any experience, but it's a very interesting idea.
There is a well-known study where I can't remember who did it, but this study has been done with tumor resections, awake resections of tumors, brain tumors, where there has been mapping of every single part of the motor cortex, and where you can also see which areas overlap. Of course, in Christian's case, it's a matter of two different sides of the brain. And in order to form new connections there, I think that's going to be hard. So I think there has to be some indirect reorganization in order to make this happen. Whereas when you have the 5-7 transfer, you actually have these neurons lying next to each other, and you will be able to rewire in the real sense, you know, with connections between the neurons, and I think it's two different mechanisms that you. I think both things can happen, but I think it's more difficult to do the indirect way. But I think I mean, as I said before, if you don't do it, nobody will do it. Okay, so if you don't try it, you will not know if it will work or not, because it hasn't been done before. So I guess this is how you can sometimes help patients, sometimes you don't help them, but I certainly think that if he can use this function to lock his knee.
Yeah, exactly.
So he has his brace on his foot because he lost his sciatic function, which is of course also bad. But if he can swing his leg forward to lock the knee, there has to be some sort of brace that he can have on where he can actually lock the knee and he can stand with the function that you gave him. He may need an external orthesis of some sort to be able to click it, but if he can do that, he can basically go from sitting to standing with what you have given him. So I think that is great. So
I will
I
keep you
think both
updated.
yours and Willem's cases are examples of this, having the toolbox and having a problem and maybe not having seen it before, but knowing what can be done and what is most likely to make a difference. I think that is really nice from both of you. I congratulate you for being so so fantastic to do the peripheral nerve surgery. It's just great to look at.
Thank you. There's a question if the presentations will be available online. Yes. Anna, who is here with us, and I will not miss the occasion to thank Anna very, very much for her ongoing support and for dealing with all our schedules and not schedules and back and forth. So Anna, if I think you can hear us, thank you very much again for your patience and your fantastic support. And Anna will be also the person who will provide the YouTube channel with this session. So yes, it will be available. Nikolai Nikolov, he just expresses that he's somehow like what we just presented. And in the chat, you find the link for the webinars to rewatch. And do we have anything? There's no more questions from the participants. Any of you with some remarks? I think we had a very nice.
Maybe we should mention the pre-congress course.
Yes, this is very important. Thank you very much for reminding. So in Sofia, this year we will have the annual meeting of the ENS, and as we did in the last 3 years with very, very good feedback and very happy participants, there will be a pre-congress course on Sunday 13 of October, which is a day dedicated to the peripheral nerves. So we will go through anything that is relevant for peripheral nerve surgery, and we explicitly address people who have not been in touch with peripheral nerve surgery so much or not at all so far. So it's like opening the door to peripheral nerve surgery, and we will have a very, very nice faculty. We will cover most of the we will cover compression, tumor, and trauma and pain. We are working to have hands-on ultrasound as well, and we will not completely change, but we will modify the program in a more case-based way, like you saw today, because we all agree that this is the way to go for to have it more practical and more related to a real problem. But of course, there will be lectures on general principles and so on. So everybody who is interested and would like to spend a day with the nerves and with us is warmly welcomed to join us in the course. During the main congress, there will be two parallel sessions, a masterclass and a plenary session on peripheral nerves, in which we will have a mix of invited speakers and of course the abstracts. So since the deadline is still open, please submit abstracts for peripheral nerves. It would be great to have you in. And as we mentioned before, everybody willing to join us and to have this exchange of ideas will be mostly welcome to our group for the business meetings online or the business meetings in person. And well, for the plenary session, we will prepare something special. new format. So we will basically tell a fairy tale with different speakers. So be prepared and be welcomed to Sofia this year.
And do not forget that we will also have virtual reality. You can check
Exactly.
that out also in the pre-congress course. We will make it possible during the coffee breaks, I think, to have a look at the virtual reality options. So don't miss that either. And look out for the ugly duckling.
Exactly. Exactly. Okay. So there are no more comments, no more questions. So I would repeat my thanks to all of you to join us, to prepare the cases, to discuss, to spend your time with us. And once again, Anna, thank you very much for all the great organization and well, keep in touch with us. So see you soon. We will announce the next webinar. It will be in about 3 months. Thank you very much. Good night.
Thank you very